This graph here shows how the blood glucose level changes over the course of a day, where each spike here represents the spike in the blood glucose level following the glucose load in a meal. As discussed in the previous video, these spikes in blood glucose levels are detected by the pancreatic beta cells, which leads to an increase in insulin secretion, shown by this red curve here, which closely follows the spike in the blood glucose level, and therefore leads to the blood glucose level returning to baseline, followed by the insulin level also returning to baseline. In states of insulin deficiency, namely in type 1 diabetes, patients need to have adequate insulin on board to prevent DKA and prolonged hyperglycemia after meals. The best way to do this is to have an injectable insulin regimen that closely follows this physiological pattern of insulin secretion. You can give long-acting insulin, for example optishulin, once daily, which has a pharmacodynamic profile as shown by this green curve here, which, as you can see, covers your basal level of insulin. It is important to note that long-acting insulins, with the exception of detamir, do not have a significant peak effect, and therefore the risk of hypoglycemia is relatively low unless very high doses are given. If high doses of basal long-acting insulin are required, you can often split these doses into a morning and a pre-bed dose. For example, 30 units twice daily as opposed to 60 units once daily. Now, in order to cover the blood glucose spikes following meals, we need to use a different type of insulin known as short-acting insulin, which have a pharmacodynamic profile shown by this yellow curve here. This curve mimics the physiological spike in insulin following spikes in blood glucose, and can therefore effectively bring down the glucose level to baseline, as it has a peak action at around 30 to 90 minutes and a duration of action of around 3 to 4 hours, depending on the subtype of short-acting insulin. Furthermore, as opposed to long-acting insulin, short-acting insulin has a significant peak effect, and therefore has a significant hypoglycemia risk if too high a relative dose is given. Therefore, generally speaking, short-acting insulin should always be given with meals, as the glucose in meals acts as a buffer to prevent hypoglycemia. So as you can see, in type 1 diabetes, the purpose of the short-acting insulin is to cover the glucose load from the meals, whereas the purpose of the long-acting insulin is to control the basal blood glucose level and to prevent diabetic ketoacidosis. This type of insulin regimen is known as basal bolus insulin, and patients with type 1 diabetes will be on basal bolus insulin if they haven't transitioned to using an insulin pump. In type 2 diabetes, where there isn't an absolute insulin deficiency, but may develop a relative insulin deficiency in advanced disease, patients may also need to take insulins to control hyperglycemia. Patients with type 2 diabetes often don't need to have as strict an insulin regimen as a basal bolus insulin regimen, which is essential for type 1 diabetes patients. And regimens for type 2 diabetes include things like a single basal long-acting insulin dose once daily, or mixed insulins, commonly twice daily, for example including things like Novomix 30, which consists of 30% short-acting and 70% long-acting insulin. More recently, there's also the option of using ultra-long-acting insulin, namely degludec, which has a duration of action of around 36 to 48 hours, as opposed to the standard long-acting insulin, which has a duration of action of around 24 hours. It is usually still prescribed as once daily, but theoretically can be taken once every 2 days, which may be preferable for some patients who have issues with compliance. In Australia, degludec is available as a mixed insulin known as Ryzodec. Now, while the basal bolus insulin regimen would be the most stringent at maintaining good blood glucose control, it does involve 4 subcutaneous injections per day, whereas the other regimens will only include 1 to 2 injections once or twice per day, which would be more convenient for patients and potentially improve compliance if this is an issue. The point is that insulin regimens should be prescribed based on the patient's preferences, the pros and the cons. In terms of the pros, we know that good blood glucose control in the short term can decrease risk of microvascular complications as seen in large-scale diabetes trials such as ADVANCE and UK-PDS. However, to get cardiovascular disease and mortality benefit, patients need to have good blood glucose control for an extended period of time in the range of 15 to 20 years, as observed by long-term follow-up in the VADT and UK-PDS studies for type 2 diabetes and the EDIC study for type 1 diabetes. So, for example, if you had a type 1 diabetes patient who was young and otherwise healthy, you would want to aim for tight blood glucose control in this patient and a low HbA1c of around 6.5% for 15 to 20 years, as this sort of intensive blood glucose control will likely lead to cardiovascular and mortality benefit for these type of patients, at least at a population level. In contrast, if you had a frail elderly type 2 diabetes patient who had difficulty with functioning and had a high falls risk and a substantial risk for hypoglycemia, then intensive blood glucose management with a basal bolus insulin regimen would not be great in this patient, because the obvious risks do not outweigh the benefit, which would largely occur only in the long term. More conservative management with a higher HbA1c target of 8 to 9% would be more appropriate for these patients. Frail elderly patients are also not good candidates for insulin therapy for practical reasons, such as they may not have the dexterity to inject insulins due to things like arthritis, they may have things like poor vision and possibly dementia. Now, in the inpatient setting, sliding scale insulin is another regimen that is commonly used, where insulin is given with meals at a dose based on the pre-meal blood glucose level. Now, as you can imagine, this is not physiological, as the insulin administered is dosed to get the BGL from an elevated level pre-meal back down to normal, but it does not cover the glucose load that is associated with the meal that is taken when you're administering this sliding scale insulin. And hence, sliding scale insulin is often just a way to ensure the blood glucose levels don't get too high, but does not actually get very tight blood glucose control. In a short inpatient admission, this is often acceptable, as the macrovascular benefits really only come from long-term tight control, as previously mentioned. And recent studies have shown no benefit from tight blood glucose control compared to sliding scale insulin in the inpatient setting, which supports the use of sliding scale insulin over aiming for unnecessarily tight blood glucose control in the inpatient setting. So now that we've talked about the considerations involved in prescribing insulin regimens, and we have an understanding of the basal bolus insulin regimen and other regimens, we can go on to discuss some simple calculations we can use to help us prescribe a starting insulin regimen. Say we have a patient that we've just decided to transition off an insulin infusion with a new diagnosis of type 1 diabetes, and we need to start the patient on a basal bolus insulin regimen. The most important thing to know about the patient is their weight, because from there we can calculate their total daily dose of insulin, which is roughly 0.5 units per kilo per day. This dose is then split into 50% long-acting insulin and 50% short-acting insulin, which is then further divided over the 3 meals per day. Another important concept to understand is the insulin sensitivity factor, which calculates how much the blood glucose level will decrease for every unit of short-acting insulin that is administered for the patient. The insulin sensitivity factor is calculated by 100 divided by the total daily dose of insulin. And thirdly, we have the insulin carbohydrate ratio, which calculates the number of grams of carbohydrate that is covered per unit of short-acting insulin that is administered. The calculation for this is 500 divided by the total daily dose of insulin. So the first TDD calculation is useful for starting a patient on an insulin regimen because it estimates how much long-acting and how much short-acting the patient will require. The insulin sensitivity factor is useful when you're trying to treat a patient with hyperglycaemia because it allows you to estimate how much short-acting insulin is required to get the patient's blood glucose level back down to a normal target range. The insulin carbohydrate ratio is useful for type 1 diabetic patients because they can use this ratio to calculate how much insulin they need to cover the amount of carbohydrates that they're taking in a meal. So as a very simple example, say you have a patient who has type 1 diabetes who weighs about 60 kilograms and has a total daily dose of about 30 units. Their insulin to carbohydrate ratio is 500 divided by 30, which is 16.667, or roughly 15. Say the patient then decides to have a bowl of plain white rice, which has about 50 grams of carbohydrate in it. Therefore, they will need to administer 50 divided by roughly 15, which is about 3 and a bit, or 3 to 4 units of short-acting insulin to cover the carbohydrate in this meal. Patients with type 1 diabetes are often very good at carbohydrate counting, and they are able to calculate how much carbohydrate is in their meal and use this insulin to carbohydrate ratio to calculate how much insulin they need to administer for themselves to be able to cover the carbohydrate in the meal that they're eating. We'll now go on to give example calculations for the total daily dose of insulin and the insulin sensitivity factor. So let's go back to the patient that we have transitioned off the insulin infusion with a new diagnosis of type 1 diabetes, who has a weight of 72 kilograms. The total daily dose of insulin for this patient is calculated as 0.5 times 72, which is 36 units per day. This can be split into 18 units long-acting, as 50% of 36 is 18, and 18 units of short-acting, which is the other 50%. This 18 units of short-acting can then be split between breakfast, lunch, and dinner. So for example, 6 units for each meal, assuming that they eat roughly the same size meals. You can use this calculation to work out how much long-acting insulin you should give the patient prior to transitioning them off the insulin infusion. So for this patient, you would give them 18 units of long-acting insulin, ideally at least 4 hours before taking off the insulin infusion, and then aim to take off the insulin infusion around a mealtime, say breakfast, and give them 6 units of short-acting insulin to cover their breakfast as well. The final starting insulin regimen for this patient would include 18 units of long-acting insulin once a day, as well as 6 units of short-acting insulin for each of their meals over breakfast, lunch, and dinner. This is a good starting point and can obviously be titrated based on the patient's actual response to the amount of insulin that is given. For example, if a patient eats relatively more for dinner and relatively less for lunch, then you can give relatively more short-acting insulin for dinner and relatively less short-acting insulin for lunch. The 0.5 units per kilogram per day formula is a good average ballpark for patients in general, but you can use 0.6 units per kilogram per day if you're trying to achieve tighter blood glucose control, or if you want to be a bit more lenient, you can use 0.4 units per kilogram per day. Ideally, you should be titrating short-acting doses based on the amount of food that the patient is eating per meal, as that is what the short-acting insulin is there to cover. And you should titrate the long-acting insulin dose to achieve better baseline blood glucose control. So for example, if the long-acting insulin is given once a day in the morning, you can then check the evening or pre-bed blood glucose level and titrate your long-acting insulin based on that reading. If the long-acting insulin is taken pre-bed at night, then you can look at the morning pre-breakfast blood glucose level to use that reading to titrate the long-acting insulin dose. When you are titrating the doses of insulin, you generally only want to change it by about 10% at a time, although you can sometimes do a bit more than this if there's a particular urgency. If the patient has an elevated blood glucose level, particularly in the morning, it is important to determine if this is from the dawn phenomenon or the Somogyi effect. In the dawn phenomenon, the blood glucose level will rise progressively overnight to a high level by dawn, usually because there's inadequate basal insulin on board. And so the treatment for this is to actually increase the nighttime basal insulin dose, or avoid very high evening hyperglycemia by having better control of the glucose load taken at dinner time with short-acting insulin. In contrast, patients can have the Somogyi effect, where if the dose of insulin at night is too high, the patient can get a hypoglycemia overnight and therefore get a rebound hyperglycemia by the morning. And so the treatment for this is actually the opposite. It is to reduce the dose of the long-acting insulin if given at night, to prevent an overnight hypoglycemic episode. To distinguish the dawn phenomenon from the Somogyi effect, you just have to do a blood glucose level in the early hours of the morning, say 3 a.m., where a relatively low blood glucose level would be in keeping with the Somogyi effect, whereas a relatively high blood glucose level would be in keeping with the dawn phenomenon. In patients who are fasting, you cannot give them their regular short-acting insulin dose, as there's a high hypoglycemia risk without having meals. However, it is still important to give their regular long-acting insulin dose in order to prevent DKA, particularly in the setting of type 1 diabetes patients. If the patient is fasting, you just have to give them around 50% of their regular long-acting insulin dose instead. If the blood glucose levels are labile and the patient remains fasted for something like surgery, it is common that the patient will be put on an insulin infusion where they can have their blood glucose levels closely monitored and managed. Another common scenario that is encountered is when a patient has steroid-induced hyperglycemia, with a midday spike in their blood glucose levels after taking the steroid tablet in the morning. If the hyperglycemia is severe enough to need insulin therapy, a morning dose of intermediate-acting insulin such as protophane can be given, which will have a peak effect around the midday spike in blood glucose and therefore mitigate this hyperglycemia effect of the steroids. So now going back to this example patient where we've transitioned them off the insulin infusion and now they're on a stable basal bolus insulin regimen. Say for whatever reason their blood glucose level spikes up to 24 in the evening despite having their short-acting insulin to cover their dinner, which may have been inadequately dosed. Generally speaking, if the blood glucose level is less than 20, there's no great urgency to try and bring the blood glucose level down with stat doses of insulin, as you can titrate this regular regimen and try and bring down the blood glucose level that way. But when the blood glucose level starts to get quite high, you may need to give stat doses of short-acting insulin to bring the blood glucose level back down to target again, which is typically around 6 to 10. So to determine how much insulin we must give for such a patient in this scenario, we can calculate their insulin sensitivity factor, which is 100 divided by their total daily dose of insulin, which is 100 divided by 36, which is approximately 3. So this means that if we give the patient 1 unit of short-acting insulin, their blood glucose level will drop by about 3 millimoles per liter. And so to get their blood glucose level from 24 millimoles per liter to 12 millimoles per liter, we need to give them 4 units of insulin, because 4 times 3 is 12. And their blood glucose level should drop from 24 to 12 in roughly 3 to 4 hours time, which is the duration of action for short-acting insulin. In these situations, patients can have stat doses of short-acting insulin without meals because you've calculated how much you're aiming to get their blood glucose level down by with the insulin sensitivity factor, and giving them meals would mean that you'd have to then give extra insulin on top of that to cover the meals, which is unnecessary and counterproductive in this situation. In my experience, this ISF calculation tends to underestimate the true ISF in patients with advanced type 2 diabetes, and can sometimes overestimate the true ISF in patients with type 1 diabetes. But nevertheless, it is a good starting point. And any previous readings that you already have in response to short-acting insulins will give you more information to determine what dose will work for the patient. You'll see in most patients that giving roughly 4 to 6 units of insulin when patients have quite significant hyperglycaemia is often adequate. But this can be grossly inadequate when patients have very high total daily doses of insulin. As an example, say you have a patient with type 2 diabetes who is on 100 units of long-acting insulin and 40 units of short-acting insulin split between breakfast, lunch, and dinner. Their blood glucose level is 32 millimoles per liter. How much insulin should you give this patient to treat their hyperglycemia? Well, their total daily dose of insulin is 100 plus 40 plus 40 plus 40, which is 220 units per day. Their insulin sensitivity factor is calculated by 100 divided by 220, which equals 0.45, or roughly 0.5. Therefore, if we want to get their blood glucose level from 32 to 20, a drop of 12 millimoles per liter, we will need to give them 24 units of short-acting insulin to get this effect after about 3 hours. Then, if, say, that goes exactly as calculated, and we then want to get their blood glucose level from 20 to 10, we need to give another 20 units of short-acting insulin because of the insulin sensitivity factor of about 0.5. You can see how if you just gave this patient 4 to 6 units of stat doses of short-acting insulin, the blood glucose level would not decrease by much at all. And so in these situations, being able to do these calculations becomes quite useful. I should also stress that you should not give short-acting insulins within 3 hours of the previous dose, because they can have a stacking effect which alters their pharmacodynamic profile and makes these calculations inaccurate. It's important to note that the insulin sensitivity factor calculation presented in this video of 100 divided by the TDD is for glucose with the units of millimoles per liter. If you use glucose with the units of milligram per deciliter, the insulin sensitivity factor calculation is 1800 divided by the TDD. So that brings us to the end of this video. I hope you now have a better understanding of diabetes, diabetic ketoacidosis, and insulin management in terms of the underlying pathophysiology and the clinical application. Here is a slide of the key take-home messages that we've discussed throughout this video for your review. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.